Good morning, everyone. My name is Sai Iyer. I'm a developmental behavioral pediatrician, and it gives me great pleasure to introduce the grand round speaker for today. Dr. Nicole McDonald is an assistant clinical professor in the Division of Child and Adolescent Psychiatry here at UCLA. She's a clinical psychologist and researcher who specializes in the early identification of autism. Dr. McDonald's research focuses on the early social development in infants with elevated risk for neurodevelopmental conditions. Currently, she has a K23 award from NICHD to longitudinally study early social and brain development in infants who experienced extended NICU hospitalization, as well as a DoD award focused on identifying and treating behavior problems using parent-child interaction therapy in children with tuberous sclerosis complex. Clinically, Dr. McDonald is an attending psychologist at the UCLA Cannes Clinic, where she conducts autism-focused evaluations primarily in young children and oversees the practicum program. She also helped to develop and co-leads the PCIT clinic at UCLA with Drs. Mogil, Orellana, and Hisaka. Today, she will be presenting on research related to her K23 award, which she has carried out in collaboration with our UCLA High-Risk Infant Follow-Up Clinic. Over to you, Dr. McDonald.
Thank you, Dr. Iyer. All right, let me pull up my slides. Okay, great. So I'll just remind everyone, questions are welcome throughout. We'll answer them at the end, but if one pops to your mind, please send them over so we can chat about that at the end. So as Dr. Iyer said, today I'm going to be presenting to you guys about some data and just kind of generally the topic area of my K23 award. This is the first time I'm presenting some of these data, so I'm excited to talk with you all about it, and bear with me because it's a new talk that I put together for this. All right, so I don't have any conflicts of interest to report related to this talk. And just to kind of review some of the educational objectives, things that I hope that you guys learn from today's talk. So learning about kind of what are some of the neurodevelopmental outcomes we see more commonly in babies and kids who had spent some time in the NICU, understanding kind of what their needs are, as well as some of the interventions we have right now, but also some of the gaps in areas where we could do better. Okay, so I first just wanted to kind of talk about what brought me to this work. So my background has been in studying kind of early development. So in that way, it was a natural fit. I'd previously been working with baby siblings, so children who have a family history of autism, to be able to kind of understand development in this different contexts and kind of how autism arises. We also knew that, kind of in at least some subsets of NICU graduates, mostly we know about kind of preterm babies, there is a higher incidence of autism. We were having some conversations with Dr. Iyer and some others in pediatrics in the high-risk clinic who do amazing work in following these babies, the ones who are kind of most at risk. And kind of learning about that there was this concern for autism and maybe a need to learn some more about that. And so these are a really interesting group of kids who have a huge, as you'll see in the data, like a really wide range of outcomes. And I'm really interested to see kind of what are some of the factors, can we learn more about kind of who's going to do really well, and some of our kids are just ahead in development, and other kids have a lot of needs, and including autism and developmental delay and behaviors and things like that. And so we want to kind of learn more about that as well as how to help. I had already started being interested in this and had started this grant, and then I ended up personally having some experience relating to it as well, where I had twins and they were born 5 weeks early and a bit small. So they had also spent some time at the UCLA NICU here. And so I kind of got some experience both in terms of like the kind of the nice moments about it and kind of how supportive some of the staff was, but also kind of some of the difficult things about being separated from your new baby or babies, and, kind of the limitations and the kind of differences between, how it was when I had my older child. And he was with me constantly, and he came right home with me. And these babies where, I kind of had this forced separation. And so that sort of deepened my kind of understanding and, kind of want to do better for these kids. Okay, so I will start with talking about kind of a model of developmental risk in NICU graduates, and I'll get into some detail on some of the background of how we're thinking about kind of, some of the factors that may play into why these children are more likely to have, developmental delays, social communication concerns, autism, things like that. So there's kind of these varying risk factors that kind of put them off on a start that's really different from kids who haven't, had those medical complications and haven't spent that early time in the NICU. Which, kind of then we see kind of early on, there's differences in brain development. We see kind of some early signs of delay, but then over time, for some subset of the kids, we're seeing kind of more substantial delay where it's kind of getting more in the way of their daily life and learning. Okay, so just thinking about biological risk factors, there's a lot of things. So the sample that I'm talking about today in this, the group of children that are served by the high-risk infant follow-up clinic, are really diverse in terms of their medical needs. So quite a few of them, I'll show you about half of my sample, were born either very or extremely preterm. So, kind of that's a really common risk factor. And most of the research we have is focused on preterm birth as something that can affect brain development. There's also kind of a lot of variable medical complications, direct insults to the brain, and some of the children have either known or unknown kind of genetic risk factors or genetic diagnoses that can affect brain development. So there's lots of things that are happening where it makes sense that the brain is developing differently in these children. So, some of the things, again, preterm infants are a more cohesive, but and also more common group of children. So a lot of the research has focused on these children. So we know that there's differences in kind of structurally in white matter tract development. So kind of the connections in the brain. We also see that functionally as well. There's different kind of patterns of connection. A lot of these studies are done, at term age or while they're in the NICU or right before they're kind of discharged to the NICU. So we see these differences early in life. We do see some differences that, kind of in circuitry in the brain that's associated with social functioning, which may kind of explain some of the social differences we see, as well as, kind of resting state networks, connections between the thalamus and higher level cortex. And some of these brain differences have predicted out to, kind of lower cognitive abilities, higher autism features, some of those neurodevelopmental outcomes that we look towards. So we have some evidence that, one, there is definitely identifiable brain differences using MRI and EEG, and that they have relevance to kind of concurrent behavior, but also to kind of like longitudinal outcomes as well. So this, kind of definitely seems like kind of an important area in terms of understanding who's at risk, what's going on, and then also potentially kind of like what might be some ways to sort of intervene and see how those interventions are working. Okay. So there's also differences in the environment, some consistently and some depending on the family. So the NICU setting in itself is a different place to spend your first weeks to months of life than going home after 1 to 3 days in the hospital, and then kind of being in the home environment and being with your parents all the time. Depending, it can look different depending on the NICU, but kind of at the UCLA NICU, for example, there's space for parents, but it's there, you know, you're not spending the night so much, like you're not spending all day with your child. A lot of families also have other things that they need to do. They may need to work during that time because they need to be ready for when their baby comes home, or they may have other children, which was in my case, the situation too. So you know, kind of they're, you know, kind of not being held as much. And there's just a lot of medical concerns that really take the forefront in their care. So it's a really kind of different situation. And that can have an impact on the parents. So one of the, you know, kind of there's that initial difference in the social environment. And then during the transition home, there can be some differences as well. One, these kids have a lot of ongoing medical needs. There might be a lot of doctor's visits, and that can be also very stressful to have to care for a child with such high care needs. It can be traumatizing to, you know, during the birth, during the NICU experience and being separated from your baby. So trauma symptoms, depression, anxiety, a lot of mental health concerns are more common. In a lot of the work is on mothers, but surely on kind of all parents involved in the situation. And those may persist in some cases. There are also, you know, kind of higher rates of mental illness that require that higher level of care, which is, you know, kind of an additional stressor for sure on the family. And then there's some idea that maybe there's kind of some of these kind of those biological risk factors can impact the baby's behavior and early development in a way that can make it harder for them to parent in some cases, which also could have kind of downstream effects. And we know kind of more stressed parents can make it harder to meet our child's needs as well as we would like to. And then also pretty well established is just kind of getting to the NICU and things like preterm birth. There are very significant disparities related to race, ethnicity, and economic status. So, for example, Black mothers are more likely to kind of go into preterm birth, and lower income mothers as well. So this is, you know, kind of a general stressor in raising a child in many cases. And there's also some maybe particular stress. There's been some research kind of talking to lower income families about kind of their child coming home. And they talk a lot about these additional stress and challenges during that kind of transition home. So that's definitely an important time to support. And we know that kind of this, you know, may lead to kind of more difficulty accessing help, and kind of there could be downward effects of that on children's developmental outcomes. Okay, so there's all these different factors that in a very complicated way, and I'm focusing on risk. There's also a lot of resilience and protective factors that come in, but focusing more on risk. You know, this really kind of leads to this different early social environment. And these are kind of all, you know, interacting together, we think, to lead to these different outcomes. Okay, so then what is some of what we know about neurodevelopmental outcomes? So, you know, kind of some of the kind of really consistent findings. So lower birth weight, lower gestational age, you're more likely to have these adverse neurodevelopmental outcomes. There is still an increase even if in those kind of more moderately late preterm kids. But, you know, kind of the earlier you're born, of course, medically it's more complicated, but also developmentally those rates increase. There's pretty high levels, it depends how you measure it in the age, of cognitive impairment. So kind of some general cognitive delays. And it's looking like somewhere around 7%. It varies quite a bit. Prevalence of autism in preterm infants. Most of this means like that very preterm group versus that 1% to 2% range in the general population. So there's not enough research on this. I'm really curious about this group in Taiwan has done some really nice research here looking more detailed at the autism presentation. There's some interesting possible differences in presentation, which I feel like clinically we notice sometimes where In this particular study, it was more based on parent report. There was more nonverbal communication symptoms reported, but less social emotional reciprocity symptoms. And they also found that looking over time in this really beautiful study, that the kids who kind of looking at those trajectories over time, especially between 1 and 2 years old, we'll see that's a really important age range, that those who are kind of declining in their trajectory, not meaning a regression, but like not making those age appropriate gains, those were more likely to be identified as autistic a little later in life. So beyond this, there's kind of a bigger group of kids who are showing kind of social communication deficits. So the MCHAT is an imperfect screener, but it does, kind of identify a lot of these kids. So I think maybe about a quarter, I'll present on that in my sample, are failing. It ranges a bit, but a fairly high proportion are showing kind of developmental concerns, say around 18 months. And we're showing signs of just kind of general social delays in specific areas like joint attention or possibly empathy. So I'm curious, I really want to know more about these developmental trajectories in these kids and how they relate to these different outcomes. And one thing to note is social communication delays. I mean, kids vary a bit, and kind of the doctors who are seeing these kids have so much to be paying attention to. I mean, a lot of these kids are needing breathing support and G tubes, and are not eating by mouth, or have other areas of delay that are maybe like motor skills that are more easy to identify. So it's really easy to overlook some of these subtle signs that maybe we could pick up on a little earlier. Okay, so I'll introduce you to the nesting study. So this is my K23 study, so that I did in collaboration with Dr. Iyer and the High Risk Infant Follow-Up Clinic. So the sample of children are those who were identified in the clinic. So it's not all babies from the NICU who were eligible. It was particularly those, which is, the majority, who are identified as having a higher risk of these adverse neurodevelopmental outcomes. So here there's a ton of information. So some of the things that automatically qualify you for this state program, and to note this is a state program, and so everyone, kind of can get this multidisciplinary support. It's a really wonderful program. It's wonderful clinically, but then it's also wonderful for research, because this means that, kind of we were able to go and talk to all of the families, and everyone had the opportunity to hear about the research. So we were kind of more equitably able to reach people in that way, since everyone can, at least in theory, access it. So birth weight below 1,500 grams and gestational age below 32 weeks was kind of, you were automatically eligible. And there was a variety of other kind of either kind of medical complications or kind of interventions that also would qualify you. So we have I'll show you on the next slide, we have a mix of kids here. So the study was initially designed before COVID, so I had to make some adaptations to it. So we followed the same age range. We followed babies from 6 months to 24 months. When I talk about age, for those who were born preterm, I'm talking about their corrected age, so based on their expected due date, for all of these kind of ages. So all of the data are going to be based on their expected due date. So we kind of were interested in developmental trajectories. We plan to, but we're limited in terms of overlapping data to also look at them in relation to babies with a family history and low risk babies. But today I'm just focusing on the high risk NICU grads. So we also have EEG to look mostly at just kind of spontaneous brain activity and how it looks over time and how it relates to some of these behavioral measures. And then I'm really curious to see kind of how much we can kind of predict those outcomes are 24 months to see. Again, some of these kids are blowing milestones out of the water. They're doing, they're ahead of expectations, and some are very behind, and everywhere in between. Some of the changes we made for COVID were, of course, we paused the study. We had to restart. These are, kind of a particularly high risk sample of children. And so we reduced the in-person visits. So we did what we could from home for the first 2 visits. And then we minimized their time by doing kind of a hybrid design. So we had to just kind of make some differences to measures in that way. Okay. So I talked a little bit about recruitment, but just to provide a little bit more detail, we did track, how many families we told, or at times the high-risk infant follow-up clinic team very kindly told some families about this study as well. So we usually had someone there every Tuesday to kind of let families know about the opportunity, with the main kind of draw being that they're getting this extra developmental information and monitoring. So we took a lot of care to communicate to families and communicate with the clinic when concerns arose, and we kind of wrote letters and gave them the information and helped out if they needed support getting in touch with more resources. So the gestational age was a huge range, so a little 22-weeker up until kind of full term. We had almost half, kind of 39% who decided to sign up for the study. So we thought that was a pretty good rate. And we were able to do that within like a year and a half. So it was pretty good. We had a little bit more males than females, and that is representative of the clinic. So we don't think there's a huge bias in who signed up for the study. I have some detail about medical concerns, but this is a project with Dr. Iyer that I will need to do to kind of get lots of detail, because there's so many kind of like, we have access to medical records and stuff, so we'll be able to look. But this is basically, these percentages are kind of what we considered. We kind of just made some decisions in terms of their kind of primary qualifying, because obviously you're very low birth weight generally if you're born under 32 weeks. So it was about half of the sample was born under 32 weeks. So that was one of the factors. And then you can see kind of in terms of the neurological injury, but they're not kind of meeting those upper categories there. So most of the kids are more complicated than this and are showing, are kind of falling into multiple groups. Okay, so just quickly, the demographics here. So I think, kind of we had most of the parents, or most of the parents had reported that they were married, which makes sense given that they have a young baby, but we had a pretty notable proportion who were either kind of partnered and unmarried, or who were a single parent. Then in terms of race, ethnicity, I combined these just for kind of visual simplicity here. So Hispanic Latino was almost half, and then we were kind of split up somewhat evenly between the additional groups. So we think pretty representative as well, or maybe overrepresenting even the kind of non-white participants. In terms of family income, it's LA, so we do have a bigger proportion of that higher group, but again, it's still kind of spread among different groups somewhat evenly. So we feel pretty good about the demographics and how much it's representing this population. So this is just the kind of the measures that we used. So the green are the visits that we just did over Zoom, over the phone. And the blue are where we asked the families to come in. In most cases, we're able to get them in. So I'm highlighting here some of the data that I'll be talking about today. There's the EEG data we haven't gotten into yet, and we're still where we're at with things. So we're done through 12 months. We're still collecting those 18 and 24 months. So just some preliminary data there. We did a mix of, we did some videoing from home, we did some direct assessment, we did some parent interviews, and we did some questionnaires. Keeping in mind, we didn't want to overwhelm families too much. So we were somewhat selective. There certainly was more information we would have liked to collect. And one thing I forgot, we added a couple of things along the way based on things that we were noticing and interested in. So we did add to 24 months. We asked parents to talk about their adverse and benevolent child experiences as well, but we haven't looked at those data yet since we're still collecting. Okay, so this is, I don't have any videos, unfortunately, because they're adorable, but these are just some examples of the kind of what we're able to collect remotely. So the AIMS assessment is the Alberta Infant Motor Scales, and this one's really easy to collect remotely. So we just have a Zoom video. Most of these were done by Cami Ferrario, a clinician coordinator within my lab, and she's fantastic with the families. And we're just kind of seeing how the baby's moving when we're and kind of strengthening and what their bodies are learning to do over this first year of life, because we do know that motor is a big area of concern for these kids. And then we also did a free play interaction where we had the parent or both parents, if we can get them, spend 5 minutes just playing naturally with their child at home. So, you know, kind of with just a bunch of data that we need to code. But one way of trying to get at, you know, kind of the quality of the interaction, and then also kind of how babies are showing their social skills in this more natural interaction. Okay. So the first thing I'll talk about, we have this at every age. I'm highlighting 12 months here. So we always asked parents if they had any concerns and what interventions they were involved in, just to kind of track this and get a sense of their perspective and their access. And so, so one of the things to highlight here, a lot of the parents had at least some area of concern, which makes sense for this family. And then also, like, again, these are families who did sign up for our study, so they were probably motivated and thinking about, you know, their child's health and development and wanting more information about that. But about 70% reported some area of concern. Some of these overlapped. With at this age, kind of it being, you know, where speech is starting to creep up. We'll talk about that in a few slides. With motor and medical. Medical includes, it's like medical, physical. So it could also include like feeding, eating concerns were really very common in these children. And then the early interventions are actually quite well served in general by interventions. So this is not necessarily per child, but you can see the numbers sort of match up well. We're about, you know, 70% of the children were enrolled in, typically through the Early Start program at Regional Center. Some type of early intervention, physical and occupational therapy were the most common types. And those started, since these kids are seen at the high-risk clinic, and, you know, kind of it actually is easier to get into the Early Start program with some of these medical concerns. In some ways, these kids have that advantage of versus some of our kind of kids who have a family history of autism, where it's can be harder and you need those delays. These kids are getting into early intervention for some of their needs early in life. Okay, so here's looking at adaptive skills over the first year. So since we couldn't see these kids in person at each of these, we'd initially had plans to do these different assessments, but we use the Vineland Adaptive Behavior Skills, the interview form, to be able to kind of measure what they're doing over time. And it works pretty well. It's really highly correlated with direct measures that when we have that overlap. And so we feel like kind of pretty reliable about the data. And the questions are often quite specific, and a lot of the parents were really good at answering them. So I tried to highlight here just kind of what is that normative range, so that 100 plus or minus 15 on that standard score. So I think a few things to highlight here. This is just separated out by the specific domain area because they can vary a lot. So there is one score and it's somewhat meaningful, but they don't always go together. So, you know, one thing that we can see is that they're staying relatively stable. And when I've just kind of done some repeated measures, ANOVA, kind of quick and dirty looking at this, like we're not really seeing kind of huge, you know, upticks or downticks. So that means they're making generally the staying on rate in terms of their gains, at least when we look at this overall score from 6 to 12 months of age. Something also to highlight, they are, you know, trending below that 100 average, but the mean in this age range, especially at 6 months when there's a little less variability and fewer expectations for their behavior, is falling within that average range, that like broad average range, kind of trending low average. you can see that there is like a pretty big variety. So if we just look at like communication, we have somewhere around the high 60s to like above 120 that we're ranging from. So for me, I'm like, oh, this is really interesting. There's lots of variability. They're doing really differently. And that makes sense. They have really different kind of medical backgrounds and family backgrounds and things like that. So yeah, so they're staying relatively stable. They're making age appropriate gains. There was some mild slowing in the social skills. I don't know how much. Something about social, especially around age 1, you start to think about people outside of the family. There was some kind of COVID impacts there. So kind of keep that in mind if kids are not getting the opportunity to be around other kids or people outside of their family, that can impact their score somewhat. So that might be one of the things that's going on there. Another thing to highlight is, even though they're not substantially kind of going down over time, like we are seeing more kids in that lower range, just eyeballing it. So you can see kind of more kids, for example, over time in that motor skills, who are just really not making those gains during this time period. So we can see that that's a big area of concern. Or from 6 to 12 months, for example, a lot of our kids, we're expecting them to start eating by mouth and, eating solid foods. And those daily living skills are really affected by that if they're not starting to do that much. Okay, so this is just using the ages and stages questionnaire over the same period, just to kind of categorize the kids. It's not perfect. And it's even though it's a screener, I think it's missing some stuff, especially in the communication area, because I'll show you on the next slide. But just to kind of get another picture or way of looking at things. So we did the ASQ because it's free, it's easy for families, and kind of it's another way of looking at sort of this, even the sense of cognitive development over time when we weren't able to see them in person. So you can see like the bigger areas of concern. Funny that communication is not showing up as much. That comes up maybe more as they're a bit older. So we're definitely seeing concerns in that gross motor area. Problem solving is, I think, hard for parents to report on, but it really came up as a concern at 12 months. We'll have to look at that. We have direct measures of cognitive ability at that age. But there's a significant minority of these kids who are screening positive for these concerns, with a mix falling in that close to cutoff and below cutoff range, with kind of more of them by 12 months. So that gap may be kind of widening, or those needs may be becoming more clear over time. Okay, so this is something, it's preliminary. It's something I'm really interested in, and where we put in a grant to sort of try to address this. So we have some kids where we've seen them at 24 months. So this is 16 of them. So it's a small sample of children. So this is also using the Vineland parent interview. So when we look at 12 months and 24 months, so remember kind of earlier on, they're staying pretty stable on this measure when we look from 6 to 12 months. What we started to notice was that we were checking in with kids at 12 months. I see all the kids at the 12 and 24 month time point. So I'm kind of like, oh, a lot of them are doing really well. If they're not talking at 12 months, I'm not too concerned. Hopefully they're babbling, but like, if they don't have words yet, that's not so out of their range. If they're not walking yet, that's common in 12 months, 12-month-olds. And we didn't have as many measures of social communication given mask requirements and things. So a lot of them were doing pretty well at 12 months. And then we were checking in with them at 18 months. This wasn't supposed to be like a big time point. But we started to notice, oh, they're not walking yet. Or, oh, they're still not talking, or they're barely talking. And we were sometimes surprised who that was. And so we're really starting to notice these concerns from 1 to 2 years. Like we're like, not all of the kids, but, kind of this pretty notable number of kids are just not kind of continuing in their developmental progress in the way that we would have expected exactly. And this is an interesting age range between 1 and 2, because in our baby sibs, those kids who had a family history of autism, they 1 and 2 years is also this year where we, in many of them, will start to kind of notice signs of autism. And so this is a kind of a big kind of transitional period. And just our preliminary data. So I added some kids and reanalyzed, and it's just looking stronger, if anything. So we'll see what happens when we have a bigger sample. But a really interesting pattern I thought was those communication skills, which were like the least of our concerns in this group at like, you know, kind of 12 months and those earlier ages in a lot of ways, at least the least of our measures concerns, are not, they're dropping in a way. Some kids may be losing some skills. That happened a little bit, but more commonly, they're just not progressing. So they're not acquiring words. We expect them to acquire a lot of speech between ages 1 and 2. And they're either doing that really slowly in some cases, or just not getting any words. So we do have already not quite a few, maybe 5 or 6 kids who were either diagnosed with autism or we have concern for autism. So we have a fairly high rate there since we're looking at things with a finer tooth comb. But it's really the communication and socialization where we're not where it's kind of going down, where the mean is lower at 24 months. And you can kind of see not all the kids. So some of the kids are making expected gains. We're not seeing a lot of jumps, but we're seeing a lot of kind of downward trajectories. Whereas in the daily living and motor skills, they are staying more stable. So daily living, again, there are some kids who aren't, because there are kids with feeding issues, but like they're staying stable. Motor skills actually is trending up rather than down. So one of the things to note is that in terms of the interventions they're getting, they're really focused on, you know, kind of occupational therapy is pretty common, physical therapy is pretty common. These areas where daily living and motor, one of the reasons why those gains may be happening is they are getting more support for those skills, whereas speech, well, you're not getting it, you're automatically not getting it before 18 months, and then really slow, and COVID has made that more difficult. There's lots of wait lists. A lot of the kids, even by 24 months, are not in speech therapy, and then the kind of the quality of that therapy is really variable, like what they're doing, it's not watched very closely. So I think that's really interesting. And then, and then this is just kind of some of the data we have so far about kind of screeners. So one of the things to point out, just when looking at speech concerns and how they're kind of changing over time, this makes sense. Like parents, of course, are starting to look out for that. They're not paying attention as much at 6 months, or they really aren't there because, you know, just they're not talking yet at that age. So those concerns are really going up when we just ask openly to parents, like, is there, do you have any concerns about your child's behavior or development? That's really jumping between 6 and 18 months. So kind of about half of the parents are reporting speech concerns. Not all of those kids necessarily have like a big delay in our measurement, but there's aspects of their speech that they're noticing that aren't kind of as expected. And so that's really increasing over time. A measure that we added, and I wish we had on everyone, is the infant toddler checklist. So this is a screener that's kind of autism focused. We collected at 12 months in kind of a proportion of the kids. So this is 20 of the kids that we had it on when I did this analysis. And that communication area, even though the ASQ was not picking up on this, about 45% were falling in that concern range. There probably are some subtle things at 12 months that are showing up in that broad communication. So speech was lower, but when we look at communication more broadly, like things like gestures, and kind of like how the child is kind of letting their parents know how to get their needs met, things like that. The MCHAT at 18 months, we also collected, and at the time that we said about 32% of the sample had failed. So this is pretty close to in line with previous. Now, 32% of the sample is not going to have autism. The MCHAT's going to miss some of our milder kids who may go on to have autism or signs of autism. And certainly the kids who are more delayed are going to come up on the MCHAT because they're developmentally not doing these things, not necessarily specific to autism. And I'd already kind of talked about here. So there's pretty clear evidence between ages 1 and 2 that there's kind of these real clear areas of need, but a lot of these kids are not kind of getting support for their development in these areas. So that's something that we really kind of want to address in future work. Checking the time. Okay, great. So to kind of jump to intervention, so this makes us think, okay, so what can we do to help these kids? And there's a lot that's been done as already. So I'm here, I just kind of talk about some of the interventions that are focused on that early time period. So the family nurture intervention is an example that talks about kind of how to enrich the NICU experience. Thinking about kind of things, all of these are really focused on kind of, let's also think about development and parent-infant bonding while we're taking care of these child's like kind of physical and medical needs. And so this is a really nice kind of comprehensive intervention. It's really focused on this co-regulation piece. And so kind of some of the outcomes here have said that it's, kind of there's higher quality caregiving behaviors that they've observed kind of early in life, and that they're seeing kind of differences for the kids who were in the intervention group versus standard care in kind of how their brain is maturing during those kind of that early time period while they're in the NICU. And they used EEG to measure that. So that's kind of really, really promising. And then kind of looking later down the line, they of course followed these kids over time. That kind of mother-infant interaction that they observed earlier seems to kind of carry forward, where the kind of parents, the moms, I guess in this case, who had that different NICU experience, also kind of you saw that can affected the interaction down the line. You also saw kind of benefits for social cognition, so how kids are thinking about social situations and their kind of like physical regulation abilities. So reminding that like this is focused on co-regulation, their ability to regulate themselves down the line also seemed to be improved. One other example, there's kind of family integrated care. So this is kind of working with the NICU staff to really kind of increase the parent involvement in the baby's care. So, and this is something that kind of was important for me when my babies were in the NICU, is kind of feeling comfortable when they're so little, like changing their diaper, checking their temperature, things like that. So it was really nice when the nurses and, kind of would involve us in that. And preparing us to have them home and feeling more connected and doing kind of parent things with them. So there were some improvements with this focus on infant weight gain, how parents were feeling, like it feels good to be caring for your child. And then there were some evidence of kind of benefits down the line as well. Another example is baby triple P for preterm infants. So this is started in the NICU, but then helps with that transition home. So there was some checking in that transition home period. As I noted earlier, like that's like kind of one of those transitions that, we really want to support because honestly, it's scary when they send them home with you. And my kids didn't even have kind of, they weren't hooked up to any machines or anything like that, but still we're small and we were used to others helping us with their care. So it's really nice to have that support. They did see some long-term benefits, not so much in the behavioral area, but in cognition and motor skills. So this is really nice. Kind of, I think a couple things. One, it's hard to just get it's hard to get any intervention out there, but like there are a lot of NICUs out there. Some of them have integrated this. The family development program here works really hard with our NICU to kind of improve how families are kind of interacting with medical staff and providing support for the families while they're in the NICU. But there's just a lot of variability, and there probably always will be a lot of variability in the NICU. So we really need to work on getting these positive interventions out there as much as possible, but they're not universally accessible. And it's also likely that kind of later transition, so that infancy to toddlerhood transition I was highlighting earlier, even if you had like the best NICU experience and a great first year, like there probably are still things that are going to be more commonly coming up for these kids as they enter toddlerhood or other stages of development. And we really need some specialized interventions for these kids and these families. Okay, so kind of to that end, so in terms of future direction, something our team really, really hopes that we're going to be able to do, we have a grant in proposing this now based on some of this preliminary data, is something called PCIT for toddlers, parent-child interaction therapy. There's a downward extension of this, which is available, but we haven't, it's still being kind of tested in general, but this is like a prime group of kids for it. The main focus is supporting emotion regulation and attachment. It does help with behaviors, but that's a little less of a focus, like, because toddlers have behavioral challenges, it's pretty typical. So it's not so much kind of focused on limit setting, but kind of how to give the parent confidence for dealing with their child's behaviors. But I'm particularly interested to see if it will help with social communication development, because there's a lot of kind of like learning stimulation and following the child's lead and things that, and kind of just developmental education and support that we think might be helpful in that area. So really hoping we'll be able to do that, for 1-year-olds from the high-risk clinic in the future. Other data, we still have lots of data to look through. So we have EEG data. We initially were going to look from 6 to 12 months, but we had to kind of cut that down. So we have it at 12 months, and we do have comparison groups to be able to look at in terms of differences in brain activity. I also added just a resting state EEG at 24 months as well, to be able to look at brain changes. And that was kind of lucky because it is turning out this 1 to 2 year age range is like really interesting. So I'll be really curious to see kind of what we're noticing kind of under the surface at those ages. And then among other things, really kind of, again, the 24-month outcomes. And we have some kids who are just talking in sentences at age 2, and we have some, rare, but some kids who are not kind of like physically capable of kind of moving themselves around a room. So there's really kind of a huge range, and like to know more about how we can identify those kids early, and so we know who to get into interventions more so than we do now. All right. And then just thanks to all of you. We'll move to questions in a moment, but first, thanks to everyone for taking the time this morning. I know I'm always busy on Wednesday mornings, so I appreciate your attention, and wanted to thank all of the families who participated and spent 1.5 years with us and spent a lot of time and effort and travel. Sometimes some of the families traveled like several hours to get to us. So we really appreciate that. They're the best families I've ever worked with. And the High Risk Infant Follow-Up Clinic has been super supportive for this grant. They welcomed us every week. As we were talking to families, they wrote Cami into the schedule to go, kind of talk to families, let us slip in there, even though they had really important stuff to do with them. So I really, really appreciate that. And then my mentorship team here as part of my K-23, including Dr. Iyer, who's been helping me to learn about this population, as well as our research team. So I'll especially highlight Cami, who I've talked about, who she's the one who ended up, she is part of why we have very little data loss. She's great at making relationships with these families and making them feel comfortable and cared for. Salma Pena was our outgoing coordinator, and Viviana Rodriguez is our new coordinator, and Karina Klein is, many of you will know her. She works with this population generally and has joined the lab this year. All right, so now I'm happy to take any questions. I'll stop sharing. All right, and
Thank you, Nicole.
It looks like there's some Q&A in here.
Yeah. So thank you, Nicole. That was a really excellent talk. And I just wanted to add, all the families that we've seen after you've seen them have just been so happy with your research team, everything that you've done, and we appreciate the follow-up that we get. So we're able to work together as a team to help some of these really complex issues. So
Yeah.
really
Oh,
well
I'm
done.
glad to
Thank you.
hear that. That's really good to hear.
So the first question we have is about early intervention services. So California has relatively well-developed system for early intervention services in regional centers compared to most other states in the US. How do you think these services may impact findings compared to kids throughout most of the US?
Yeah, no, it's a really good point. Like our regional center system, as much as we may complain about it, is a big improvement across like kind of other. We've had some families move to different states during it, and always makes us like a little bit nervous. So we do have this, kind of system of support, which everyone's supposed to have access to. But yeah, I mean, I think if anything, we can expect that compared to states that don't have such comprehensive a high risk infant follow-up program, like the ones that these kids, all of these kids are in that program. So even some of the kids in the NICU are probably maybe showing more concerns if they don't end up in the program, right? So these are kind of like outside of their medical risk being elevated. These are the better outcomes. These are families who are getting to the follow-up clinic, they're getting to our study visits, they're really dedicated, they're getting easier access to early intervention services. And so you could really think this is the best case scenario. And so it may be that there's even kind of higher levels of need in other states. So it would definitely be interesting to look at this in kind of other state programs to see how things look.
The next comment and question, interesting talk, which I agree with. The question is, did you look at the possibility that some children were exposed to alcohol prenatally? If so, how were they developing?
Yeah, so we did collect information about, this is parent reported, like kind of any exposures during the pregnancy. I think all of the families are birth families. I don't think there's any, I think if there was, child protective and like child welfare involvement, those families just generally weren't in a situation where they could consent to research or go through research. But so we have some information on that per parent report that we collect at the 6-month visit that I haven't looked at, but I don't know that there's going to be many or any that were actually reported any exposures. But I don't know, aside from working with the population, how frequently are you seeing that?
I mean, we do see it, and like you said, more commonly in children who are in the foster system or later gone on like to be adopted. We do see that, and we would expect kind of more delays, more concerns with those children. But yeah, I mean, they couldn't be part of the nesting study for obvious reasons that the foster family couldn't consent, right?
Yeah, it's like a lot of the kids who end, it's like it's complicated because there's so many things going on that could be impacting, but we'll need to look at it because it might be that some of the families had reported some alcohol exposure. I haven't looked closely yet.
And then from Dr. Mogul, if we were to create information or videos that could be more widely accessible, what information would you want to include to support child development, family coping, co-regulation, etc.?
Oh goodness, I feel like our data don't speak to all of those things yet. I have to think about it some more. Catherine, you probably would be better at developing those than I would, but I'd be happy to do it. Let's see. I mean, I think, one of the things I want to look more into is kind of figuring out if there are particular things that are kind of maybe at 12 months that we should be looking at, that some of the things I'm noticing. So some of the kids who I ended up having a big concerns about, like when I saw them in depth, I noticed and I was like, yep, you might have autism. Some of the kids shocked me over time. They really surprised me. So, yeah, so I think I need to look more into the data to see what those were, but we do know some information. So maybe some of those things is just kind of getting more widely out there, some early signs of autism, kind of looking at some of those checklists. I do like the infant toddler checklist. That could be something that we could maybe integrate into the clinic a little bit more to provide that additional information. But I don't know, Catherine, I need some time to think about that one. What do you think, Sai?
I mean, I think, from something you said earlier, right off the bat, the NICU medicine in general, we work off sort of a deficit-based model, right? Every day, during rounds, they go over the baby's problem list, talk about how the baby's not eating enough, or not, it's a very deficit-based system.
Totally, yeah.
So I think, kind of strengthening, going back to that resilience and what things the baby can do, I think is very important, especially as the parents make that transition from NICU with so much support to then like going home on their own. So focusing a little more, I think, on the strengths of like, here are things that your child can do, is doing really well, would be really helpful.
Yeah, totally. And I think the other side of the coin totally is that if you look at those, like a lot of the kids are like, it's amazing I mean, we had a kiddo who was like born at like 22, 23 weeks. I mean, it's amazing. Like they're doing so much. And so we still want to meet their needs, and kind of give them everything we can, but they really are doing a lot.
The next question, are there any plans to follow up on the study to assess longer term outcomes or to explore potential interventions?
Yeah, so kind of, I had spoken this probably an earlier question too, but like, so I would love to be able to follow these kids beyond age 2. I need to find like a funding mechanism that will kind of allow that, or some way to allow that, because we definitely have some concern for things like ADHD or anxiety or other things that come up later in life, or even autism that can't be identified at age 2, as well as some of the kids may, kind of really show a lot of improvement between age 2 and 3, et cetera. So I would love to see them, but no current ability to do that quite yet. And then, we're hoping to be able to do this toddler intervention. Let's see, do we want to, given time, do we want to jump to Sierra's question?
Sure. So Sierra says, thank you for a wonderful talk. I was wondering if you have thoughts about how to speak to families about developmental risks from a NICU stay in a resilience-informed way. For example, without communicating that children will be delayed or disabled, or emphasizing variance in outcomes.
Yeah, that's true. I think a lot of families, they do talk about, it's like almost being scared. This happens with genetic syndromes as well, where it's like that maybe it could go either way, but it really is important to be able to communicate the balance. So, kind of, your baby is, kind of, they were born earlier, whatever the kind of situation is, we do know that we're going to keep a closer eye on things for them, because we want to be able to kind of give them the support that they need and that you need, so that they can learn as much as possible. So we are looking out for things like autism or just not meeting milestones. But I also want to say that, most kids, kind of now, are really doing very well. And even if they do show some of these signs, like they're still able to have like a really nice, like happy life and stuff like that. And there are things, and I think empowerment is an important thing too. Like there are things that you can do at these different stages to help your baby out. So kind of reflecting, maybe what we know about kind of where parents do have some say. And I think that's a balance too, because we don't want to put so much pressure on parents where they have to do so much beyond that care, but just like you being there for them is going to be one of the things that really helps them to learn and to grow. But yeah, I do think it's kind of a subtle thing that whenever we're talking with families of like, how do you make sure they're keeping an eye and seek help when we need it? We know some of the families where we really wish they were in early intervention, but either can't or won't. And, kind of, so enough steam, but not so much that it's turning into anxiety or they're missing all the things their baby is learning, regardless of whether that's typical for their age or not.
Great. I think those are all our questions. I think we missed one from Camilla, but she can ask you.
It's okay. It was probably helping me out question. So.
Great. Right. Well, thank you very much.
Thank you.
Nicole, that was really wonderful.
All right. Thank you guys. Bye.
Bye-bye.